Thank you to the organizers for the opportunity to present today. So the topic I've been asked to cover is the seemingly relentless and persistent march towards robotic abdominal surgery, specifically with regards to where we currently stand in terms of evidence, what the future might hold, and most importantly, where do the patients fit into some of the decision making. Now, for the rest of this talk, I'm going to be focusing on rectal cancer surgery, just for the sake of simplicity. But in reality, all the points that will be discussed are relevant to all robotic abdominal surgery, not just rectal cancer. So briefly on the evidence, the largest trial conducted in colorectal surgery is the ROLARR trial. Many of us are very familiar with this. It was a very large multi-center trial of robotic versus laparoscopic TME. So the primary outcome of the ROLARR trial was conversion to open. There has been some debate as to whether this is the ideal primary outcome in a study looking at rectal cancer surgery. Nonetheless, it recruited 471 patients across multiple continents. There was no difference in conversion to open, but importantly, there was also no difference in any of the other outcomes measured, such as postoperative recovery, short-term oncological parameters, or any functional outcomes such as urinary or sexual dysfunction. Robotic surgery was more expensive, just over $1,000 more per patient, and this was statistically significant. There were some limitations of the study, the first of which was acknowledged by the authors and influenced the conclusion, which is that some of the robotic surgeons were still within their learning curve. Despite the study having been conducted by centers that were enthusiastic about robotics, not all of the surgeons were beyond their learning curve. It is important to mention that some high-volume robotic centers did not randomize to ROLARR because they did not feel that there was equipoise or that laparoscopic TME was necessarily the standard of care. Which goes to the second point in that the comparison group, laparoscopic TME, may not have been an ideal comparison group, and I will discuss that in more detail in a slide further on in the talk. Another important study in this area is the Korean trial. This was a single center robotic versus laparoscopic TME trial. While this was a smaller study, it addressed many of the weaknesses of the ROLARR trial in that many of the surgeons were beyond their learning curve, if not all of them. This was a high volume National Cancer Institute in Korea. It also addressed the weakness of the primary outcome. In this study, they included completeness of TME, and this was a blinded assessment by pathologists. It was a smaller study, but again, there was no difference in any of the major outcomes measured. The robotic operating time was longer, and this was significantly longer. Cost was not measured, but it was assumed to be higher. And there was somewhat better recovery of sexual function at 12 months, but because of the number of variables that were measured, it's not clear if this was a real finding or whether it was just a statistical anomaly. Again, the comparison group of laparoscopic TME may not be ideal. Because the unit was a very high volume unit in Asia, it's unclear if the results are generalizable to Western units with lower volumes, and the cost-benefit analysis was not done in this study. There is one recently published high-quality meta-analysis which included 9 randomized trials with over 1,400 patients. The 2 prior trials were included, as well as 7 other smaller, perhaps lower quality randomized trials. And again, this really showed no major difference in outcomes comparing robotic and laparoscopic TME. So I briefly touched on the idea that in all of these studies, robotic surgery was compared with laparoscopic surgery, not open surgery. And from a purely academic, scientific point of view, this may not be ideal. And the reason is that as it currently stands, major trials looking at laparoscopic versus open TME have failed to establish laparoscopic TME as the standard of care, mainly because in the 2 big Australasian and US studies, oncological equivalence was not established, but furthermore, there was no recovery benefit seen between laparoscopic and open TME. So from an academic perspective, open TME, and this includes hybrid TME, where most of the surgery is done minimally invasively, but the TME itself is done open through a midline, lower midline or a phalansteal, that operation remains, academically speaking, the standard of care. And so, any new technology arguably should be compared against the current standard of care. So why did all the RCTs compare robotics with laparoscopic TME? The main reason from my perspective is bias. And essentially, the latest thing is generally compared with the last new thing, as opposed to the current standard of care. And so the question as to whether robotic TME is the standard of care is unanswered. And that's quite important because it's not cheap. This is an example of the costs in Australian dollars. The machine itself costs $3.5 million. The accessories push that up closer to $4 million. And then there's ongoing maintenance costs of about $200,000 a year, as well as reusables per case of about $3,500, depending on the instruments that are used. So the truth is, if we look at it from a practical and pragmatic perspective, and if we're being really honest with ourselves, nobody really cares about the cost-benefit equation in robotic surgery. There are no more RCTs planned in rectal cancer, and the multiple RCTs that have shown minimal benefit have not changed practice. I'm not aware of a single robotically trained colorectal surgeon that has access to a robot that has stopped doing it as a result of the data, and I include myself in this statement. Robotics continues to expand across all continents, with hospitals investing in robotic surgery and surgeons continuing to pursue robotic surgery. So why is this? I really think that the major reason is that robotic surgery represents the next generation of technical and technological advancement in abdominal surgery. There is no question that the visibility is improved, the camera technology is better, the surgeon is able to control the camera with much less movement and shaking. The wristed instruments are a pleasure to use and do make the operation in some ways easier. The fact that the surgeon's sitting down and not standing with his or her head kinked to the side or trying to use straight instruments in a narrow pelvis means that the operation is less tiring. And so while robotics has not borne fruit as far as patient outcomes, many of us feel that it is better technology and that it is here to stay. There are, of course, other less noble drivers, such as private practice pressures and industry-level marketing, which has been very successful in this area. There is a third point, which is that the future may be different. Currently, we're in the first phase of robotic surgery, and it may be that future technologies which build upon current practice will result in measurable patient benefit and reduced cost. And so we must be open to this idea. So this is the data from the Open Payments database, which looks at payments from industry to individuals and hospitals. In 2019, in the US alone, Intuitive, who are the dominant players in the robotics space, spent $55 million in payments to individuals and hospitals. 45 million of that was to individuals, mainly in the form of honoraria, food and beverage, educational activities, etc. So there is no question that the robot is being aggressively marketed, and we would be naive to think that this has not had any impact on our choices. Having said that, there are some really exciting advancements coming both on the hardware and the software side in robotics. On the hardware side, the next generation of robots appears to be focused on single port surgery, where all the instruments actually come in through a central port and then can articulate throughout the abdomen, thus saving multiple incisions. And many of the surgeons online today may have even used this type of robot. There are other companies taking a different approach where instead of the robot coming down from one boom, you can purchase and use independent arms which dock separately. This provides additional flexibility in terms of only using the amount of instruments that you need. It's potentially cheaper because you can buy 1 or 2 arms as opposed to 4 or 5. And you can also potentially use laparoscopic instruments, which will drive down the cost further. Some of the instruments are improving with improved triangulation, angulation, particularly in staplers, as well as potentially improved haptic feedback. Arguably even more impressive are the improvements on the software side. The next generation of robots are likely to come with AI implementations integrated into it, For example, the ability to recognize organs and highlight them. You can imagine, for example, if the robot was able to recognize a ureter and show it to you before you noticed it, that could be very useful. But also feedback, telling the surgeon where they may have made some mistakes, where their performance could be improved. Ultimately, even replacing the surgeon with some automated aspects. I think the latter, though, is probably a couple of decades away, but still very interesting to think about. What about patients in all this? Where do they sit in all this? Well, there is a little bit of data, so we should cover this. This is a study which looked at patient perceptions of robotic-assisted surgery, what they thought of the procedure that they had. They looked at 6 studies which measured patient perception, 5 of which were quantitative and 1 of which was qualitative, and it was mostly urology and gynae, which is where a large proportion of the robotic surgery is performed. Patients mostly reported that they were satisfied overall with the quality of the surgery they received. However, it was almost impossible to discern whether the patients were satisfied with just their clinical outcomes, independent of the robot, or whether they had any specific views related to robotics. And so the conclusions were very limited here. It was unclear, basically, if patients cared whether they had a robotic surgery or not. This is a study out of Kuwait, which actually assessed patient knowledge around robotics and compared that with surgeons. 256 patients were asked their views about robotics. It was pretty clear that most patients really didn't know very much about robotics. 61% were unsure what it was, and 10 said they had no idea what it was. 88% of patients did not know of anybody that had a robotic operation, and somewhat most alarmingly, 69% of patients either thought the robot was unsafe or they weren't sure if it was safe. When asked about the surgeon's role with the robot, a large proportion of patients really were unsure what the relationship between the surgeon and the robot was, whether the surgeon controlled the robot or vice versa. And only about 45% would choose to have robotic surgery as an alternative to conventional approaches, minimally invasive or open. So I think it's pretty clear that the advancement in robotics and the push towards increasing numbers of robotic operations is not being driven by patients. In my view, patients are at best agnostic about robotic surgery, and the limited data available would suggest that most of them are unsure about the safety or the effectiveness of robotic surgery. So I think it's incumbent upon us to, 1, be honest about the data with the patients, but also educate the patients as much as possible about the various options that are available so that they can make an informed decision. At this point in time, I would say robotics is being driven by surgeons and by industry. However, this is not all bad, and I think the technical innovation in robotics should not be underestimated. It is possible that this is the first step in a pathway that will result in technologies built on what's currently available and the practice that's currently being performed that will eventually result in significant measurable patient and surgeon benefits. And I think that idea should not be discounted. So from a practical point of view, what do we tell patients who are being considered for robotic TME? Well, it's obviously different in different settings, but I can tell you how I approach it. I only really offer robotics for rectal cancer surgery, and I tend to offer 2 approaches, either the robotic approach or a hybrid laparoscopic approach where the TME is done open. I can honestly say that I spend a lot more time talking about the TME itself, because from my point of view, all the morbidity and risk and potential benefits and quality considerations come from the TME, regardless of the technology or the operative approach that's used to do the TME. And so because of that, I spend a lot more time consenting the patients for the TME itself. And then I mention, after I've done that, that there are 2 approaches, either lap hybrid, where the TME is done open, or robotics, and I'm happy to do the operation either way. Do you have a preference, or are you happy for me to decide? Generally, if the patients understand that there's really not very much difference in outcome, and you're open and honest about that, they tend to trust you to just make the decision on their behalf. And I can honestly say that in 5 years, I haven't had a single patient demand one approach versus the other in my practice. And so often it comes down to practical considerations like, is there a robotic list available within a suitable time frame? particularly with regards to considerations of neoadjuvant treatment, patient social factors, and the like. So I hope that gives somewhat of a pragmatic overview of where we're at with robotics, what the implications are in terms of quality and cost, and where I think patients stand in the discussion. I'm hopeful that we continue to progress down this line and we can have honest and open discussions amongst ourselves and the patients as to what the best techniques really are and continue to improve the quality of their care. Thanks again for inviting me to talk, and I'm happy to take any questions.